Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the Endocrinology Committee. A warm welcome to all the respected dignitaries and faculty for today's event. Today's theme is key issues in obstetrics and gynecology, and we continue this theme focusing on important issues for day-to-day practice. Before we begin the scientific proceedings, I would like to express my gratitude to the amongst office bearers. Our esteemed President, Dr. Nandita Palshekar. Madam is the current President of AMOX. She has also served as a President of the Mumbai Society, IAG in the past, and also the Toxicity President. She is the Vice President of ISAR at present, and we thank her for her blessings and her guidance in all the academic endeavors that we have had over the past 1.5 years during this pandemic and lockdown period. Next slide, please. I would also like to express my gratitude to the Secretary of AMOX, Dr. Arun Nayak. Sir is the current Secretary of AMOX. He served as a President of the Mumbai Society in the past and is a distinguished vaginal surgeon in his own right. Thank you, sir, for blessing us with your approval for all our events. Next slide, please. At this point, I'd also like to express my gratitude to the ICOG office bearers, our Chairperson of ICOG, Dr. Uday Thanawala, the Secretary of ICOG, Dr. Ashok Kumar, for granting us credit points for all our events conducted over the past 6 months, and also for today's event, which is accredited with an ICOG credit. Next slide, please. We have a host of eminent stalwarts who are here today as chairpersons for today's event, and the senior most of these is none other than Dr. Kiran Kurtakoti, sir. Sir is the second Vice President of AMOX. He's also served AMOX in several different capacities over the past 15 years, including chairperson for the MTP committee, chairperson for medical education, research and training, also as the second joint secretary of AMOX way back in 2009. He's also been chairperson for the FOXY MTP committee from 2009 to 11, well known as an organizer of several conferences in Pune, where he hails from, in a different era when we used to have physical conferences. And we hope to have a physical conference in Pune as well very soon. Hopefully the Delta wave doesn't prevent that. Thank you so much, sir, for gracing the occasion. Next slide, please. We also have with us a dear friend, Dr. Varshala Ade. Madam is the zonal coordinator of AMOX. She's passed out from BJ Medical College in Pune. She's also been the organizing secretary for the Nashik OBGYN Society conferences. She's currently the vice president of AMOX, she's vice president-elect of AMOX for 2022-23. She's also served on several different committees, and she's been part of the academic events in AMOX as well as in FOXY. Published several papers in international journals. She's been a national speaker for gestosis as well. Thank you so much, ma'am, for being with us here today. Next slide, please. We are also graced by Dr. Pranjal Saraswat Sharma. Madam is a senior consultant in Amravati. She's organized the last physical conference of AMOX, which was held in Amravati in February-March of 2020. And we remember that conference with fond memories because that was the last time we could all be in the same physical space. And very soon after that, the pandemic took over and completely disrupted all our lives. Madam has also served as the Vice President for PCPNDT, State IMA 2018-19. She's also Chairperson for the Beti Bachao, Beti Padhao campaign for the State IMA 19 and 20. Zonal Coordinator, as I just mentioned, and she has also been the organizing chairperson for the Adolescent Zonal Conference for AMOX. Thank you so much, ma'am, for joining us despite your busy schedule. We have 3 eminent stalwarts from OBGYN as speakers at today's event, and they are going to be talking to us about practical issues in OBGYN. The first of these is Dr. Manisha Patrikar Takade. We also have with us Dr. Ashish Kale, and last but not least, Dr. Asha Jain, ma'am, a very senior and distinguished faculty from Raipur. To conduct the scientific proceedings further, I would like to hand over to the chairpersons, and I request Dr. Kiran Kurtakoti, sir, to introduce our first speaker of the day, Dr. Manisha Patrikar.
At the outset, thank you very much, Dr. Pratik, for inviting me for this particular seminar, and I think it's a wonderful job that you're doing. Even though we are not meeting physically, as you rightly said, that last was the Amravati conference, which Pranjal and everyone had organized so nicely. So everyone is, all of us are looking forward to meet each other. So let's hope, wish and pray that the third wave doesn't hit us. In the meanwhile, AMOGs and POJs, as you all know, are going to Maldives. Many of you are going to come with us. Varsha is there, of course, but we will miss out on others also who not will be joining us. So anyway, it's a pleasure for me to chair this particular seminars of yours, Pratik, as always. And you are really bridging the gap between the Maharashtra societies and the entire FOXY. And it's a pleasure for me to say hello to Dr. Asha Jain, President of Raipur Society, for being associated with us on this platform. Without much ado, it's a pleasure for me to invite the first speaker to speak on the role of antioxidants in infertility. Her name is Dr. Manisha Patrikar-Kate. Dr. Manisha is a very enthusiastic member of the Aurangabad Society. She is the director and consultant and endoscopic surgeon, certified colposcopist at Anand New Spring Fertility Center, Aurangabad. She's worked in MGM Medical College and Hospital for 7 years and into private practice since 4 years. Published many articles, in many national magazines. She is the vice president of the Aurangabad Society, received the Best Society Award of AMOGs in 2018-19 during her secretaryship. She's the president of Lions Club of Aurangabad Angels 2020-21. She's received she's a very media savvy person. Okay, there is another media savvy person of Pune, Dr. Ashish Kale. And but anyway, Manisha is a very media savvy person. She has received the Times of India Maharashtra Times Appreciation Award for contribution towards development of Marathwadi region, which is indeed a great effect. And most recently, everyone saw us winning the Lokmat Best Women's Achiever Award quite as recently as it passed in the last 15 days or so, I think, Manisha. So really, it's a great pleasure and honor to chair this session for you, Dr. Manisha. And without much ado, I would request you to take us through the journey of antioxidants in infertility. Thank you.
She is not audible.
Am I audible now?
You're audible, visible, your slides are seen. Please proceed.
Yes. First of all, thank you so much, Kiran sir, for such a kind introduction. And I'm really thankful to Pratik Tambe sir for giving me this opportunity to share this presentation today. And with warm regards to all the chairpersons and all the delegates, I would like to start my presentation. Role of antioxidants in infertility. Now, very much is known about this topic and very less is still known about this topic. So I take pleasure in sharing my views about it. Now, we all know that oxygen toxicity is an inherent challenge to the aerobic life. And it is chiefly that oxygen is essential for life and so many physiological processes as well. And at the same time, excess oxygen can have harmful effects to us. When oxygen is metabolized in the body, it produces substances called free radicals, which damage our cells. And this reaction takes place in a way in the presence of energy ATPs. Free radicals are produced, which damage the cells, which damage the tissues, and they in turn cause diseases and disorders. Now, this oxidative process occurs in all the cells and tissues throughout human body. So constantly this oxidation and reduction is taking place, and oxidation reaction can produce free radicals. These free radicals are produced by the exposure to pollutions, the ionizing rays, the UV rays, air pollutions, smoking, fatty foods, we all know as junk foods, used or consumed at large in these days, then the stress, which is not the least factor. And all these factors, they will give rise to cell and DNA damage too. These free radicals are like robbers, which are themselves deficient in energy. They attack and snatch the energy from all the other cells to satisfy themselves. Free radicals cause damage by oxidation, and these free radicals are highly reactive and can cause damage to the molecules in cells. ROS are the key signal molecules in many physiological processes to maintain cell homeostasis. Whenever there is excess, they precipitate the pathologies. And that's why this ROS acts as a double-edged sword, giving rise to conditions like asthma, arthritis, CVD, Parkinson's, diabetes, cancers, and infertility. So the question arises that are we ready to fight this attack of oxidative stress? Counteracting this radical damage, the only defense that we have at this time in the war against free radicals is by antioxidants. Now, what are the antioxidants and what is the science behind the antioxidants? We all are aware to the basics that this browning reaction is due to the oxidation process. When all the fresh fruits or veggies, they come into contact with the oxygen or the pollutions. Now, this is a very small, interesting, and basic experiment to show that oxidation occurs when there is this apple left exposed to the air. And the same apple, when it is protected or dipped in orange juice containing antioxidant vitamin C, you can see there is no oxidation taking place. So this proves that antioxidants, they mop up the free radicals, they convert the ROS to water. We can call them as scavenging molecules. Now, lipid peroxidation occurs, or antioxidants, they prevent lipid peroxidation and oxidative damage to the protein, oxidative damage to the DNAs, and antioxidants have low redox potential and will sacrifice themselves to prevent this oxidative damage. Etiologies of unexplained infertility and recurrent pregnancy losses remain unclear still and present as a scientific challenge to us. Oxidative stress is a piece in this puzzle. Now, increasing evidences to show that oxidative stress affects both natural and assisted fertility. It affects the it causes tubal infertility, polycystic ovarian diseases at large, abortions, then embryopathies, hydatiform moles, unexplained infertility, and endometriosis as well. Oxidative stress is associated with age-related decline in fertility, decline in ovarian function, and decreased steroidogenesis. Now, further, this contributes, and the ROS negatively affects the oocyte maturation, decreased oocyte presentation of penetration of sperm, and decreased fertilization and blastocyst development occurs. Decreased implantation occurs, and increased loss of implanted embryos also occurs. So, this oxidative stress affects multiple physiological processes and the oocyte maturation to fertilization and embryo development. Reactive oxygen species and the endometrium. Now, there is a cyclical variation in the expression of the superoxide bismutate in the endometrium. And in the late secretory phase, this SOD activity decreases, the level of ROS increases. And it is important for the endometrial shedding and also the onset of menstruation. Reactive oxygen species and the ovaries. Now, various biomarkers of this oxidative stress has been demonstrated in normal cycling human ovaries. A delicate balance exists between the ROS and antioxidant enzymes in the ovarian tissue. Now, these antioxidant enzymes, they neutralize the ROS production and they protect the oocytes. Hence, it's so important. And the role of ROS in endometriosis is that an increased generation of ROS by pelvic macrophages and increased lipid oxidation in patients with endometriosis is seen. And antioxidant levels of superoxide resume were noted to be significantly lower in the peritoneal fluid in the patients of the endometriosis when studies were made. Now, the increased ROS levels in the tubal and peritoneal environment negatively alter the fertilization and the embryonic development. Hence, and role of ROS in PCOS. So, elevated insulin resistance and hyperhomocysteine has been proposed to be caused by oxidative stress in patients with the PCOS. And the antioxidant supplementations have been shown to improve the insulin sensitivity as well. The decreased antioxidant status and the increased oxidative stress levels may contribute to the increased cardiovascular morbidity in these patients. Now, what is the impact of this oxidative stress on the assisted reproduction? So there are multiple sources of ROS generation in the patients undergoing therapy, and they are like oocytes, 5 per dish, then cumulus cell masses, sperms or prolongation of the sperm, oocyte co-incubation time for more than 20 hours, or ROS level in day 1 culture media might also affect. Now, impact of ROS on assisted reproduction would be the same thing. That is, causes a perturbed redox state and affects the development of the embryos by altering the gene expression, impaired adenosine triphosphate production, then 2-cell arrest of the embryos and embryopathies also. ROS levels can be utilized to counsel these patients with IVF. All these oxidative stresses influence the entire reproductive span of a woman's life and even thereafter, that is, during the menopause as well. Now, how do we measure these ROS and OS levels? Now, there are many different ways to test these antioxidants. Out of them, there are electron spin resonance method, stable peroxidation production concentration. But no standard reference values, no defined sensitivity and specificity is there. Hence, these tests are not used on the daily basis. They're only for the experimental purposes. Now, strategies to overcome oxidative stress in infertility and ART. When oxidative stress is diagnosed, treatment must be focused on identifying and eliminating the sources of these ROS, which is the base and which is the most important part. So, the patient should be asked to quit smoking, or alcohol consumption should be stopped. Obesity has to be treated, or weight reduction has to be done in these patients. Stress factors also have to be eliminated, and meditation also serves good, and counseling has also to be has a very bigger role in stress management. Then poor dietary habits also have to be correct. And only after the treatment of these primary etiologies should the patient be advised to take antioxidant supplements. Only then they will give the largest of the benefits. Now, these antioxidants in food may or myth or a magic medicine. Now, for that, we need to know the role of each ingredient. And here are few antioxidants, which I would like to stress upon. Iron, more important mineral for general well-being and energy. A subtle deficiency of iron may cause female subfertility, does cause. And magnesium is helpful in unexplained infertility since most have micronutrient deficiencies with ROS. In vitro studies have shown oocyte activation on exposure to the magnesium. Zinc is essential cofactor for several metabolic reactions. Zinc deficiency impairs the synthesis and secretion of FSH and LH, and abnormal ovarian development also takes place. And irregular ovulation may occur due to all these factors, and impairment of the oocyte maturation also takes place, hence giving rise to female infertility. Now, when we give these patients supplements of zinc, it regulates the ovarian development, improves the oocyte maturation and ovulation, and exerts beneficial effect in female infertility. Vitamin C is the most important antioxidant in extracellular fluids. Vitamin C is a chain-breaking antioxidant and it protects the tissue against oxidative damage. It is also helpful to recycle the oxidized vitamin E and glutathione. And vitamin E is the strongest antioxidant at present, a free radical scavenger, is also called as, and it protects the DNA and the cell from the damage. Beta carotenoids or beta carotene, provitamin, these is present in the group of red, orange, and yellow pigments found in the plants, particularly the fruits and vegetables. And this also enhances the ovarian function to the large. And acetylcysteine, NAC, a powerful antioxidant. It increases the reduced glutathione at cellular level and acts directly on the reactive oxidant radicals. And this antioxidant effect exerts a protective effect to the cells. And it is not found in the diet. We have to depend on the supplements for consuming this. Now, additional benefits of NAC are that it improves the insulin sensitivity as well, preserves the vascular integrity by vasodilatory effect. Anti-androgenic effect is also there, and hence it decreases the testosterone levels and also decreases the free androgen index. As an antioxidant, a mucolytic agent is detoxifying harmful substances in the body and promotes the sperm motility and survival in the female genetic tract. Now, L-arginine, a semi-essential amino acid, well known as precursor to nitric oxide, lower levels of L-arginine causes delayed conception and decline in the oocyte fertilization and implantation rate. Hence, nitric acid induces endometrial secretions at implantation time. It's very important to give this. And nitric oxide increases the endocervical secretions at the ovulatory phase of the females. And this has shown to increase the cervical secretions and improving the chances of conception. L-arginine supplementation was reviewed in the patients with thin endometrium and high radical artery resistance index. So 9 patients were given this L-arginine and 10 control patients were not given any medications. And it was noted that this L-arginine had improved the RARI, that is radical artery resistance index, by 89% out of 9 patients, and endometrial thickness in 6 patients, that is 67% patients, which was seen in only 1 patient in the control group. So it states that it has improved the RARI and increases the uterine blood flow and the endometrial receptivity. Now, the sources of these L-arginine are many. They are like the dairy products, the animal products, vegetable sources, nuts, and the grains as well. Grape seed extract. Now, this is the most potent antioxidant that we have till now. And there have been studies demonstrating that this grapeseed extract causes inhibition of free radicals to 78 to 81% as compared to the vitamin C, which did 12 to 19%, and vitamin E 36 to 44%. Then it lowers down the production of ROS by around 70% when given in the dose of 20 to 100 milligrams per kg. And with this, if compared, vitamin C, when given 100 milligrams per kg, reduced the production of ROS by only 18%, and vitamin E by 47%, and beta carotene by only 16%. As you can see, the grapeseed extract gives the greatest of benefit, right? Inhibition of the free radicals by lowering down the production of ROS. Now, the green tea or vitamin B6, B12, it reduces the free radical damage and improves overall reproductive. Now, these green tea catechins are 100 times more potent than the vitamin C. Hot cocoa tops and red wine and tea is an antioxidant, and 2 to 3 times more stronger than the green tea and 4 to 5 times stronger than the black tea. Now, this vitamin B12 and vitamin B6, deficiencies of vitamin B12 and B6 gives rise to increased oxidative stress, failure in ovulation, and defective implantation, thus giving rise to female infertility. And these supplements, they reduce the oxidative stress and improves the ovulation, and thus improves the reproductive health. Now, what happens with the deficiencies of this folate? Homocysteine and oxidative stress increases, which reduces the folliculogenesis, and the production of inflammatory cytokines increases, and this alters the nitric oxide metabolism, and apoptosis takes place. And all these, they lead to female infertility. But when the supplements are given, improvement is definitely seen. Selenium. Selenium works synergistically with vitamin A, and it's very important to be supplemented. So the natural sources are nuts, seafood, and antioxidants in combination. Now, all these antioxidants are believed to work better in combination than supplementing alone. So together they protect the oxidation of each other, and together they produce the need of large doses of a single nutrient. Then we come to the main factors of infertility, which is around 50%, 30 to 50% in the rising. And this main factors, they are also highly influenced, that is 30 to 80% due to this oxidative stress. Now, this oxidative stress, it gives rise to free radicals, as we all know, and then this ROS and RNS are produced, and this ROS, they are supposed to cause a lot of DNA damage, and the RN species, they will damage the proteins, carbohydrates, nucleotides, lipids, and cause sterile inflammatory changes and additions. And hence, there is a need for continuous inactivation of these by antioxidants, but maintaining a small amount for normal cell function as well. Now we can see these antioxidants and ROS and the oxidative stress. If we look at the etiologies, around 80%, 30 to 80% are due to the increasing ROS exposure. And now, damage to the sperm DNA results in infertility and miscarriages, and damage to the sperm membrane decreases the motility and the sperm's ability to interferes with the oocyte. That is, it affects the fertilization. Then this oxidative stress causes damage to the plasma membrane. DNA fragmentation occurs, decreases the fertilization rate, and early embryo death also occurs. And decreased sperm motility is seen. Now, these affect normal embryonic development. Why are the sperms sensitive to oxidative stress? As the plasma membrane and the cytoplasm contain large amount of polyunsaturated fatty acids, they are more vulnerable to ROS. And significance of the immature and abnormal sperms is in the semen is seen. Now, immature and abnormal sperms and pus cells produce a lot of ROS. Poor sperm quality is linked to the increased ROS generation as a consequence of presence of excess of residual cytoplasm. Now, how can we reduce the stress? Treatment with antibiotics to handle the infection is important to decrease the ROS production. Then supplementation of media used in IUI, IVF, or ICSI have not proven to be that very useful. And shortening the centrifugation time while sperm preparation is again important because the centrifugation also increases the ROS production. And oral supplementation is found to be the most useful tool that we have at present. So oral oxidants were available and commonly used for. So vitamin C. Firstly, again, I would like to add upon that first the etiological factors have to be removed and then to start these antioxidants to the male partners. And vitamin C protects against DNA damage and supplementation helps in increasing the sperm count and reduces the agglutination. Then vitamin E prevents the ROS-induced damage to the sperm membranes and improves the sperm counts and potency of the sperms. Then coenzyme Q, concentrated in the mitochondria in the middle piece and involved in the energy production. Glutathione deficiency results in instability of the middle piece, resulting in abnormal motility. And ginseng improves sperm parameters and increases the erectile capacity. Selenium helps to improve motility and the it is synergetic with vitamin E, so it enhances the effect of the vitamin E as well. Zinc involves in testosterone production and sperm formation and motility. Arginine. Now, essential amino acids found in sperm head are due to this arginine. Lycopene. Now, this is important in maintaining the quality of gametes and supports the reproduction. Omega-3 fatty acids. Now, these fatty acids are used as a source of energy by the sperms. And carotenoid. Now, these carotenes are used by the spermatozoa for the mitochondrial beta oxidation of longer chain fatty acids. These being the principal shuttle and transfer system of the acetyl to the mitochondrial CoA. The carotenoids acid enhances the circular energy stick in mitochondria by facilitating the entry and utilization of the free fatty acids with the mitochondria and also restores the phospholipid composition in the mitochondrial membrane and it decreases the fatty acid oxidation.
Sorry to interrupt, ma'am. You have 5 minutes to go.
Yes, sir. And this improves the motility of the sperms. Then we have different studies also which have proved that the subfertile males may improve the outcome of live birth and pregnancy rates for subfertility couples undergoing the ART cycles. Now, when we have supplements are used in these patients, there is a marked improvement of clinical pregnancy rates, that is 48.2% versus 6.9% to that of the natural. And the implantation rate is also improved to 19.65 versus 2.0. Hence, the role of antioxidants is very importantly proved in the male infertility. Now, there is a lack of consensus on the type and dosage of the antioxidants to be used. Validation by large randomized double-blind case-controlled trials is still needed for the evidence. Now, take-home messages. Oxidative stress has a significant impact on female and male infertility, and the role of oxidative stress in female reproduction and male reproduction cannot be underestimated. The best way to add antioxidants to the diet is to eat generous servings of fruits and vegetables daily, right from childhood. Now, while treating the male partner, oral oxidation treatment appears to improve the outcome in infertility and other ART procedures as well, like Pcos, in those patients with the sperm damage, the DNA damage, in whom this treatment reduces the percentage of damaged spermatozoa, and general guidelines are like this treatment should be given for 3 to 6 months at least, or at least for 74 days, that is one spermatogenesis of cycle, before we start treating them. If no improvement or conception occurs, then these patients should be referred on time to the ART clinics. That is the most important line, and should be given before the ART to improve the outcome of these cycles as well. And majority of medical treatments need further placebo-controlled crossover randomized double-blind multicenter trials to prove all this. Antioxidants optimize the environment and offers complementary role to correct and support female factors as well as the male factors and the conception. Lastly, I would like to end up on a note by Marcel Proust that the real voyage of discovery consists of not in seeking new landscapes, but in having new eyes. This is a different perspective. Thank you so much for the patient hearing, as it is a post-lunch first session. Thank you so much.
Thank you, Dr. Manisha. It is one of the most comprehensive talks that I have listened to as far as antioxidants are concerned. I really didn't imagine that there was so much material on antioxidants which was available. So thank you so much. I would request you to please hand over your slides to Dr. Ajay Mane so that he can post it on the AMOS website. So this will be beneficial to everyone. So thank you so much. Any questions from the audience?
So no questions so far. If there are any, we'll take them at the end of the
Thank you so much. Thank you, Dr. Manisha ji. Thank you for that talk. Thank you.
Can I request Dr. Varshala Ade to please introduce our next speaker, Dr. Ashish Kale?
Hello, am I audible?
Yes, ma'am. Please go ahead.
Yeah. Good afternoon, everyone. Thank you, Pratik, for giving me the opportunity. Hello, Manisha, Kiran, everyone. And today, it's my pleasure to welcome this gentleman, Dr. Ashish Kale. He is the director of Asha Kiran Hospital, Pune and Baner. He is the director of Arunachal Test Tube Baby Center, the founder member and librarian of Maharashtra chapter of IAG. He is the executive member of National IAG 2019 and 21. Also, an executive member of Maharashtra chapter ISAR, MISAR, as well in 2018 and 21. Executive member of National ISAR also, and he has published many papers, posters, research articles at many national and international journals, and presented many papers, posters in many national and international conferences. Yes, of course, he's an international faculty because I recently said that he's on Facebook and doing every day something about the academics, and I am also his follower. So welcome, Dr. Ashish, for your talk. Welcome.
Thank you, Varsha Madam, for those lovely words. At the outset, I'm really thankful to AMOX family. I'll not say AMOX because I am one of the member and I'm a family member of AMOX. So they say when you're talking about the Vandan, we have to Vandan the elder ones. So I have to say I'm grateful to President Nindita Madam, Secretary Arun Naik Sir, Committee Chairperson, Endocrine Committee Chairperson Dr. Pratik Tambe, as well as a Vice President and my friend Kiran Kurtokodi Sir for giving me this opportunity to talk and share some knowledge of mine to all of you. So here I'm sharing my screen. And at the outset, I'm really thankful to our committee chairperson for helping me out for certain reasons. So when you're talking about the insulin sensitizers in a PCO, all of us knows that the PCO has a two groups, PCO, lean thin PCO and obese PCO. When you're talking about the obese PCO, we need to understand there are certain problems related to the endocrinology of the obese PCO. Obese PCOS do have the obesity is one of the problem, but the underlying problem is the insulin sensitization. And they are having hyperandrogenic features and hyperinsulinemia. And these are the two problems make them anovulatory, make them obese, make them irregular menstrual patterns. And that is the problem we need to address. And then what comes into our rescue, just see in a few minutes. So the most common when you look at the PCO, what is the girl walking down to you, or the any reproductive female coming down to you? What actually you look at is a something like this. Is she may complaining of hyperandrogenism, chronic anovulation, and maybe a polycystic ovaries, where it is a sonographic diagnosis. What you call as a sonographic diagnosis when you have done a sonographic pictures and the radiologist telling that it is a cystic ovaries. So cystic ovaries doesn't mean that it is a polycystic ovaries. So you need to understand there are certain endocrinological factors that has to be taken into account. The prevalence, why we should be much more worried about the PCO, whether the PCO is really a national problem or whether it is really a world problem, one should be near to understand. The global prevalence of the PCO is 2.2 to 26%, and per se, if you're talking about the India, that is our own country, it is something lying down to the 36%. The signs and symptoms, there is no need that I should be talking much more about the signs and the symptoms because all of us are daily treating these patients. So these are the patients when you look at the girl she's obese, irregular menstrual patterns, there is a sense of hirsutism like acne, hyperandrogenism features and acanthosis nigrans. These are the particular features you need to know at the back of mind. These are the patients are having a polycystic ovaries. Actually, why this particular problem occurs? The problem is not because of the obesity per se. It is a multifactorial. It is a multi-endocrine system which is evolved. You have known that there is increase in LH amplitude and as compared to the FSH release, and this causes LH to FSH ratio is disturbed, and that causes anovulation. Coming down to the obesity, there is called as hyperandrogenism and SHBG levels, which is the sex hormone binding globulin levels in the liver is going to get reduced down, and that's why you have a hyperandrogenism. And hyperandrogenism in per se causes a disturbance in insulin release, and then you have a hyperinsulinemia. And these all multicystic disorders in the endocrinological pathology will lead to a irregular menstruation and anovulation per se. So when you're talking about the diagnostic criteria, it's not something new. Polycystic ovaries are coming into the pictures in the Steen-Leventhal syndrome. That is not something that we are talking something new in this 2021. But see, there are the pictures which is changing everywhere. Our mobile phones are changing. Our life perception towards the life is changing. We are now coming down to the Zoom platform, and everything is changed. So the same terminology of the PCOD now changed to the PCOS, and PCOS having a genotypes A, B, C, and D. One should be knowing and depth of what is I'm talking about A, what is when I'm talking about B phenotype, and when I'm talking about D phenotype. The thinking that where it has to have a majority of the common features is hyperandrogenism and irregular menstruation. See, only the polycystic ovaries on a sonography, that doesn't mean it is a polycystic ovaries. You need to understand that is a phenotypes A, where you have a sonographic pictures, you have androgenic features, and then she's a patient of anovulation. If she is a phenotype B, where the sonographic pictures of PCOS is not been there. When you're talking about C, where there is a endocrinological components are not there. And when you're talking about D, where where you are thinking that there is a hyperandrogenic is a common features. So the patients of PCOS is related to the infertility when coming down to you. What is the modality of treatment is changing in lifestyle. If you ask me whether it is really suitable to give the option to the patient just to change and reduce down your BMI, it's not that great. You are not, the patient is not that much happy when you're talking about some diet, exercise and diet, because they want instant results nowadays. None of us are wait to lose the weight and then coming down to us for fertility treatment. So what we'll have in our armamentarium is ovulation induction. What is ovulation induction? In this particular scenario, you can have a first line of a treatment is letrozole. I will not go into the details of it, but one should be knowing the letrozole is the first drug of choice as far as oral ovulation is considered in a PCO. Then it comes down to clomiphene. Of course, the gonadotropins and LOD will not go into the details where when to do a LODs and when to do a gonadotropin stimulation in a PCOS, because that is not my today's talk. The treatment in adolescent and lean women, at the outset I talked in the first sentence of this talk, I talked when the patient of PCOS comes into two categories, lean thin PCOS and obese PCOS. If the obese PCOS patients coming down to you, what is the line of treatment? Is lifestyle modifications, is a weight loss, nutrition and exercise. Which exercise? Any exercise which will cause you a loss of your fat, and usually a 75 minutes a brisk walk can also be taken into account. Then coming into the insulin sensitizers, if you wanted to reduce down the weight, you can take the help of metformin. That is our favorite drugs for all the gynecologists for years together, and also with myoinositol and D-chiromyoinositol. What is the best thing of the metformin? The metformin, it causes a weight reduction. It restores the ovulation. Live birth rate is increases. The first line medications when there is a hyperglycemia. I'll come down to that. What does I mean by the HOMA index, and I will be talking that in a little while. Then coming another insulin sensitizers is a myoinositol and D-chiromyoinositol. It decreases the serum androgen concentration. If you're having the patient of hyperandrogenism, it is better to give those girls a myoinositol rather than a metformin, because this myoinositol and D-chiromyoinositol decreases the androgen concentration. It improves the oocyte qualities as well as the embryo quality. When you're talking about the fertilization rates and the pregnancy rate, as a IVF person, we must know what is the quality of the oocytes. And when you are giving a myoinositol and D-chiromyoinositol, the quality of the oocytes is going to get improved. The treatment of the hirsutism is definitely, if you reduce down the levels of the androgens by myoinositol or D-chiromyoinositol, usually these are improved in a patients where the androgen index is high. Then someone will ask me whether I should be doing a free testosterone levels or the testosterone, total testosterone, or a SHBG. I think when you're the levels, if you wanted to do is a free testosterone levels, but I don't know how many places is this free testosterone levels have been done. But if you're thinking that the signs of hyperandrogenism is there, it is better to give a myoinositol and D-chiromyoinositol, because it's decreased the reduction of the hirsutism by 15 to 30%. What is the those are the patient when coming down to you are of infertility and they wanted to conceive. What is the pre-conceptional counseling? The counseling will lead to the two things, like whether I will be going to have a good eggs and good fertilization. Then you have to talk about the insulin sensitizers like myoinositol and D-chiromyoinositol. If they are coming down to you too much of a BMI more than 35, it is better to give metformin for a certain time. And mind well, the metformin has to be given a pre-treatment, not during the treatment. Of course, you have to continue the metformin, but it has to be given pre-treatment when you are planning the patient for IVF cycle. Obesity and insulin resistance. These are the more than 50% of the PCOS are obese. What I talked to you, all of you, 80% are hyperinsulinemic, and hyperinsulinemia contributes to the hyperandrogenism through the production in the cells, which is definitely, if you follow this particular chart, you will understand if there is hyperinsulinemia increases the androgen levels, you have hyperandrogenic features. So to deal with, the first comes is hyperinsulinemia, and later you have the hyperandrogenic features. So if the patient coming down to the obesity and not having the hyperandrogenic patients, these are the patients to treat it very well rather than waiting for too long. The pathophysiological contributions is a PCOS. When you are insulin resistance is only a deciding factors, is a 60 to 80% in a PCO woman, 95% those of them having the obesity. So role of insulin sensitizers is increase the sensitivity of the insulin towards the receptors by decreasing the hyperinsulinemia. You can see this figure. There is a insulin, there is a receptors, there is called as a P13 kinase and a GLUT4. If this insulin is getting attached to the insulin receptor, this P13 kinase is going to get activated, and your GLUT4 is going to get activated, where there is no gluconeogenesis and the glucose uptake by the cell is improved. The woman with the PCOS, there is a secondary messenger contribute to the insulin resistance. So there is a deficiency of this P13 kinase activity. So in a PCO patient, if this kinase activity is not there, you have hyperinsulinemia, and these are the deciding factors. The glucose metabolism, I will not go into the details of the glucose metabolism, because one should understand only the like a clinical point of view. If you are wanted to see the patient, it is better to do a HOMA index. What is HOMA index? Is a insulin into a PSL upon 22.5. Why you are talking about 22.5? Because the 22.5 is a glycemic index which requires for neutralization of the glucose. And if it is a normal a HOMA index is between 1.7 to 2, and if it is more than that, it means you are dealing with a hyperinsulinic patient. And in those patients, you have to have decision factors regarding use a myoinositol, decarbamyoinositol, if they are hyperandrogenic, if they are just obese, start with the metformin. These are the simple way to understand the insulin sensitizers. The newer hope is a myoinositol. Why it is a newer hope? Because if you remember that a few slides back, I quoted that is a P3 PI3 kinase activity, which is low. And this myoinositol increases or activates this PI3 kinase enzyme, and which will be helpful for the glucose uptake. So if you are talking about why there is a combination of a myoinositol and decarbamyoinositol in all the things, usually the inositols belong to vitamin B complex. You must understand this. There is nothing called as epimers of myoinositol, L and D. D is much more important when you're talking about ovulation and getting a oocyte maturation. So coming down to that particular things, these are the what I was talking about: P13 kinase, PI3 kinase activities, which has been activated by these insulin sensitizers. Metabolic abnormalities improves benefits of myoinositol and decarbamyoinositol in PCOS, because it improves the insulin sensitivity, it decreases the blood pressures, BMI. Definitely, if your BMI is decreased, your BP is going to get decreased, and your fat masses are going to get decreased. Your SHBG is going to get increased by the liver production, and that's why you're not having a hyperandrogenism. And once your BMI is going to get decreased down, you have a regularization of menstruation. Then comparing the rationale between adding of a metformin to a myoinositol and decarbamyoinositol, why it should be taken into account. What is the particular way of action of a metformin, myoinositol, and decarbamyoinositol? Metformin activates the insulin receptors, decarbamyoinositol acts on the ovary, and decarbamyoinositol acts on a peripheral tissue. So if you wanted to have these particular things clear in your mind, so you will be definitely going to understand which drugs acts where. If you wanted to action more on the ovaries, it is myoinositol. When you wanted to have the actions on the periphery tissue, it's a decarbamyoinositol. And then comes down to the why there is a 40:1 ratio. I will be going to that details in a while. When you are going to add the metformin with a myoinositol and decarbamyoinositol combination, definitely a weight loss will be there. And after the weight loss, the spontaneous conceptions as well as the good quality of the embryos, because myoinositol acts on the ovary, it will increase the oocyte maturation. You will have more M2s, and that will going to have a good quality embryos which have been formed. So definitely a myoinositol at a higher doses is required as compared to the decarbamyoinositol. And when you are talking about the pregnancy rates, all of us knows that Cochrane review, the metformin is not increased the per se a live birth rate, but the live birth rate is increased in addition to the metformin. Metformin doesn't increase your ovulation rate, it doesn't increase your pregnancy rate, but live birth rate increases because metformin take care of the hyperinsulinemia and the abortion rates are low. When you are considering about the higher live birth rate, when this particular combination is being used, there is a statistical significance of using this combination of a myoinositol, decarbamyoinositol, and metformin. All of the knows that Cochrane has definitely given a way back, the metformin is superior. But when you have this combination, it is worthwhile trying for it. Metformin induces significant reduction in the body mass index. These are the trials of up till now. How it will be, that is already I've been discussed about it. Myoinositol improves the insulin sensitivities and HOMA index. That was, I was talking about the HOMA index, and this is the way forward. You cannot just do a GTT. You cannot just do a obesity. It is better to do a HOMA index, which will gives you a particular way of treatment. It is not only just to treat the insulin sensitizers. You must know the HOMA index, if comes down to normal, the chances of good quality eggs and good quality embryos are much more higher. So it is better to do this particular test prior of any drugs to be started in order to know what is the effect of the drug. And that's why I was talking about why there is a 40:1 combination. Why not a reverse way? Why we are not having a D-chiromyoinositol on higher as compared to the myoinositol? See, myoinositol is much more acting on the ovaries. D-chiromyoinositol is at the periphery. We don't want the peripheral conversion of glucose into utilization of the glucose. When it is required, when you're talking about obese PCOS, but not infertility. When you wanted to have infertility patients, it is definitely we want a normal milieu of these granulosa cells and theca cells, and that can be achieved when you are having this 40:1 ratio to deal with. Metformin is a drug of choice, no matter how you deny it or how you are selecting it or you like it or you dislike it. Definitely metformin is going to stay and it has its role to play. But the metformin has its side effects. When you give the patient the metformin, they have heartburns, they have indigestion, constipations, bloating, abdominal pain, and diarrhea. And that's why you need to have a combination of these two or three drugs, metformin, myoinositol, and D-chiromyoinositol. This has a betterment of acceptability, reduce down the dose of combinations. If you require a 1.5 gram of metformin, if you are adding a myoinositol and D-chiromyoinositol, the metformin requirement is reduced down, and that's why you have a better tolerability by the patients. Characterize reduce to the inositol, that is already I talked all this particular thing, how you decide. So I'll not go into the details again and again, but definitely you need to understand which patients require which one. It is not the drug for all. It is not the drug for everyone. It is when you have to decide whether you are having the patient of hyperandrogenism, what is the drug you required, which combination of the drug. So definitely hyperinsulinemia, if you are considering only that, then it is a metformin. If you are having a hyperandrogen component, you have to add myoinositol and D-chiromyoinositol. Oxidative stress, the previous speakers talk about the ROS, its role in infertility. So definitely there is a role. If you have the obesity and there is a definitely these are the patients are likely to have a more ROS, and that will decrease our success rate. And these are the what I talked again the same way. FSH messengers increase the FSH signaling. You will get a good quality oocytes and maturation when you are adding a myoinositol as compared to D-chiromyoinositol. Then someone will ask me, well, what is the role of N-acetylcysteine? It's a good drug. It's not a bad drug at all. It also improves the ovulation, pregnancies, lowers the androgen levels. It regulates the menstrual cycles, but provides the immune support also. But it has to be taken into account in a later date. It should not be just a routine drug in our prescription. These are the combinations when you combine myoinositol with N-acetylcysteine in improvisation of menstrual irregularities. These are the particular when you are giving these drugs for adolescent PCOS, where the irregularity of menstrual irregularity is the problem. Role of vitamin D3, nowadays every company come up with a different combination permutation, but as a clinician one must know really we required as an Indian of vitamin D3 in our supplementation, and how much is the role. Definitely it improves the insulin resistance, it increases the longer maintenance of ovarian reserve. We know a POR and DOF patients require this vitamin D supplementation, but not for all. So the take-home message, definitely a PCO is a common problem. If you think of the PCO, thin and obese, insulin sensitive, hyperinsulinemic, hyperandrogenic, decide the dose, decide the drug, and there is a lot of things in your prescription when you are having a permutation of combination of a metformin, myoinositol, D-chiromyoinositol, myoinositol, N-acetylcysteine for adolescent PCOS with the irregular menstruation. So think patient-wise. Don't think like a laparoscopic surgeon, infertility specialist. You have to think for the patient view of style when you are treating the patient as a whole. Thank you very much for patience hearing.
Yeah, it was really a lucid presentation, Ashish, and you talked about and given justice to Cairo and de-Cairo-inositol. Thank you so much. And I would like to ask one question. What about the TZ?
What about?
What about the TDZs? New insulin sensitizers which are used in type 2 diabetes mellitus. Are they useful in infertility?
You mean to say
There are other, yeah.
You mean to say a TDZ where there is a there is a type 2 diabetes where there is a definitely a patient is having higher glucose in the blood circulation, and all of us knows that increase in the blood sugar levels increases the ROS. So definitely, and we know this because of the glycemic index, the chances of abortion, chances of malformation is much more high. So definitely in those patients where it is a type 2 diabetes, you have to give this prior to the conception and make it a point that HbA1c is a good tool where the patient is not knowing about their status of a glucose.
Okay. Thank you so much. Thank you.
Thank you, Pratik sir, for giving me an opportunity.
Hand over the mic to.
Thank you very much, Dr. Ashish, for being here with us. We know you're extremely busy and very much in demand. So it was finally good to have you with us because I've been wanting to include you since quite some time. Thank you, Dr. Shalade ma'am, for conducting that session so expertly. As yet, we have no questions from the audience. We have one final talk to go before the beginning of the Q&A session. I would request the audience to post any questions if they are relevant to the talk so far in the chat box, and we will take them at the end of this next talk, which is by a very eminent speaker, Dr. Asha Jain. And for her formal introduction, I hand over to Dr. Pranjal.
Thank you, Amma. I convey my regards towards Dr. President Dr. Nandita Palshetkar, Madam, Secretary Dr. Arun Nayak, Sir, VP Dr. Pardesi, Sir, and respected Dr. Kiran Kurtuputi, Sir. Dr. Pratik Tambe, very sincerely and meticulously, he's mapping his journey of bridging Bharat and adding stars to the endocrine committee of committee as a chairperson. So thank you, Pratik, for involving me. And without much ado, let us listen to Dr. Asha Jain, Madam, who will be talking on one of the most intricate hormonal topic, that is endometrial hyperplasia. It is indeed a privilege to introduce Dr. Asha Jain, Madam. She's a director of SMSA Raipur, medical director CPRS Raipur. She's an elected member for CGMC 2024. She was a secretary IMA Raipur 2019-21. She is president of Raipur Obstetric Gynec Society since 2018 and will be till 22, President Rotary Club, and indeed an eminent speaker. I welcome you, Asha Jain, Madam, and we are eagerly waiting to for your pulse of wisdom on endometrial hyperplasia. Over to you, Madam.
Thank you, Dr. Pranjal. Thank you, Dr. Pratik, sir, for having me here and including me in your distinguished program. So, you know, it is thanks to these lectures that we also learn a lot. We learn a lot because endometrial hyperplasia is something we see in and out in our OPDs every single day. And we don't really think what to do. It's sort of ingrained, what we have learned, what we are practicing. But when Dr. Pratik gave me this topic, I started studying. And there is so much to know and so many new changes. So how do we define endometrial hyperplasia? That is the first thing that we need to know. Because you see, when you get a sonography report, many a time it's mentioned there is endometrial hyperplasia. But endometrial hyperplasia is defined, just a second. Endometrial hyperplasia is defined as irregular proliferation of the endometrial glands with an increase in the gland to stroma ratio when compared with proliferative endometrium. Each word is very important, that it has to be compared to a proliferative endometrium So when you are looking at the endometrium, it has to be in the estrogenic phase of the cycle. And there is an increase in the gland-stroma ratio. Then it is called endometrial hyperplasia. Now, these recommendations that I'm going to speak about are from the Green Top Guidelines 2016. And these are the various classification of evidence levels. 1, 2 plus, 1 plus, 1 minus, 2 plus, 2 plus, single plus, and then 2 minus. And as you go down from A++ to 4, the gravity of that evidence keeps going down. And then there are, based on these evidences, you have grades of recommendations. So A is the highest, and then there are good practice points that come down. So A, B, C, and D. These are the various levels, because we will be doing the recommendations and we need to understand what this means. When it's a tick, it means it's a recommended best practice based on clinical experience of the guideline development group. But evidence per se is not there. So first of all, we are going to talk what are the risk factors for endometrial hyperplasia. We all know menstrual factors, that is an older age, postmenopausal status, nulliparity, infertility, early menarche, late menopause, anovulation, menopausal transition, and or polycystic ovarian syndrome. Then iatrogenic factors where unopposed exogenous estrogen therapy or tamoxifen is given. Number 3 is comorbidities. Comorbidities, that is obesity, diabetes, hypertension, or Lynch syndrome. Now, colorectal cancer syndrome, which is also associated with endometrial and ovarian cancers, is the Lynch syndrome. So all this, if any of these are present, then it becomes a high-risk case. How do you classify? So in 1998 came the first classification, which classified endometrial hyperplasia into 4 categories. One was without atypia, one was with atypia, and it was simple and complex. So simple hyperplasia, then complex hyperplasia without atypia, then simple hyperplasia, complex hyperplasia with atypia. This classification had been going on, but it was creating a little bit of a problem. Then in 2004, they introduced another classification, like we do CIN, cervical intraepithelial neoplasia. They added endometrial intraepithelial neoplasia. This new term was coined, which included the abnormal, atypical hyperplasia. After that, WHO revised this guideline in 2014. And that is the classification which was published in 2016 and is the one that is recommended to be used now. This classification separates endometrial hyperplasia into 2 groups based upon the presence of cytological atypia. Please remember cytological atypia. So it could be hyperplasia without atypia. Chances of malignancy 1 to 3%. Atypical hyperplasia includes endometrial intraepithelial neoplasia, and the chances of coexisting malignancy could be as high as 60%. So these 2 are entirely different things. And when we talk about the management, we have to understand that these diagnoses are by cytology, by histopathology, and not by looking at it. So once we have the diagnosis, then we have to learn how we are going to treat it. How are we going to diagnose it? How is a patient's surveillance started? So the diagnosis of endometrial hyperplasia requires histological examination of the endometrial tissue. This is something we need to, just mark on our heads that yes, this is it. So any patient who has abnormal bleeding and wants a direct hysterectomy is a strict no-no. Endometrial surveillance should include endometrial sampling by outpatient endometrial biopsy. A people biopsy works very well. Up to 90% to 99% results are there in this. Then, if the office diagnostic procedure doesn't work, a people biopsy gives you an inconclusive result. Then you can proceed and do a diagnostic hysteroscopy, which is considered to facilitate or obtain an endometrial sample, especially when outpatient sampling fails or is non-diagnostic. The third thing is a transvaginal ultrasound. It may have a role in diagnosing endometrial hyperplasia in pre- and post-menopausal women. How will this be done? I will demonstrate in the next slide. Then direct visualization and biopsy of the uterine cavity using hysteroscopy should be undertaken where endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesion. So if there is a focal lesion, it is better to look in. So here you can see the slides. This first case is a case of previous cesarean section, and you can see that the endometrium is very clear. This inner portion is the endometrium, and this is a transvaginal scan, anteverted uterus, and this is the cesarean scar with a very little residual endometrium, but the myometrium. But here the endometrium is very clear. It is regular. There is the endomyometrial junction is very clear. And here is another case. You can see that the endometrium, this is a postmenopausal 56-year-old woman presenting with a little bit of bleeding after being in menopause for 8 years. And can you see here, this endometrium is reaching almost up to the level of the serosal layer. Here, much clearer in this slide, you can see this. So there is a very little myometrium left, and it has invaded all of it. And here are the vessels, which are of different shapes and sizes and occurring de novo. They are not connected to anything. They are occurring de novo. So endometrium, the ultrasound can give you an idea, but it is not something on which you're going to say, yes, this is it. You will need a histopathological diagnosis before you can say, this is this. There is insufficient evidence evaluating computerized tomography or a CT scan or a diffusion-weighted MRI or biomarkers as aids in the management of endometrial hyperplasia, and their use is not routinely recommended. So MRI or CT scan for diagnosis? No. Now we come to the management. First of all, we talk about endometrial hyperplasia without atypia. So this is the type A, where there is no atypia. There are varieties of management. There's an initial management, then there is a first-line management, medical management, surgical management, and we will take all of it one by one. Women should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over 20 years, and that the majority of cases of endometrial hyperplasia without atypia will regress spontaneously during follow-up. This is a grade B evidence. Reversible risk factors such as obesity and the use of hormonal replacement therapy should be identified and addressed if possible. Motivate the lady to lose some weight. And if you're giving HRT, you need to just be careful about how you're giving it. Observation alone with follow-up endometrial biopsies to ensure disease regression can be considered, especially when identifiable risk factors can be reversed. However, women should be informed that treatment with progestrogens has a higher disease regression rate compared with observation alone. Here, what we are talking about is not to go directly for a hysterectomy. What we are talking about is conservative management, which patient we can just monitor without anything which patient has to be given progestogens and which patient will have to be given further treatment. Progestogen treatment is indicated in women who fail to regress following observation alone, and also in symptomatic women with abnormal uterine bleeding. Now, what is the medical management? Both continuous oral and local intrauterine LNG-IUS progestrogens are effective in achieving regression of endometrial hyperplasia without atypia. This is a grade A evidence. So you can give oral progesterone, you can also give an LNG intrauterine system. The LNG-IUS should be the first line medical treatment because compared with oral progestrogens, it has a higher disease regression rate with a more favorable bleeding profile, and it is associated with fewer adverse effects. The continuous progestrogen should be used like medroxyprogesterone 20 to 20 milligram per day or norethistron 10 to 15 milligram per day for women who decline the LNG-IUS. And cyclical progestrogen should not be used because they are less effective in inducing regression of endometrial hyperplasia without atypia compared with continuous oral progestrogens or the LNG-IUS. So we have continuous progesterone for 6 months or an LNG-IUS to see whether the hyperplasia is regressing or not. What is the duration of treatment? Treatment with oral progestrogens or the LNG-IUS should be for a minimum of 6 months in order to induce histological regression of endometrial hyperplasia without atypia. If adverse effects are tolerable and fertility is not desired, women should be encouraged to retain the LNG-IUS for up to 5 years, as this reduces the risk of relapse, especially if it elevates abnormal uterine bleeding symptoms. And endometrial surveillance incorporating outpatient endometrial biopsy is recommended after a diagnosis of hyperplasia without atypia. And it can be done with the LNG-IUS in situ. So the evaluation and the surveillance has to be by endometrial biopsy. Endometrial surveillance should be arranged at a minimum of 6 monthly intervals, although review schedule should be individualized and responsive to changes in a woman's clinical condition. At least 2 consecutive 6 monthly negative biopsies should be obtained prior to discharging the lady from this regular surveillance. Women should be advised to seek a further referral if abnormal vaginal bleeding recurs or after completion of treatment, because this may indicate disease relapse. In women at higher risk of relapse, such as women with a body mass index of 35 or greater, or those treated with oral progestrogens, 6 monthly endometrial biopsies are recommended. Once 2 consecutive negative endometrial biopsies have been obtained, then long-term follow-up should be considered with annual endometrial biopsies. Please see what it is saying. Initially every 6 months, but then it has to go on with once a year. And here we are talking without atypia. We are not talking of endometrial hyperplasia with atypia. This is without atypia. Now the surgical management. Postmenopausal women requiring surgical management for endometrial hyperplasia without atypia should be offered a bilateral salpingo-oophorectomy together with the total hysterectomy. However, for premenopausal women, the decision to remove the ovary should be individualized. However, bilateral salpingectomy should be considered, as this may reduce the risk of a future ovarian malignancy. A laparoscopic approach is better because there's a shorter hospital stay, less postoperative pain, and quicker recovery. And endometrial ablation is not recommended for the treatment of endometrial hyperplasia because complete and persistent endometrial destruction cannot be ensured, and the intrauterine adhesion formation may preclude future endometrial histological surveillance. Because the cavity is partially obliterated, you are not able to get at any abnormal endometrium. So ablative therapy should not be there for hyperplasia. Now we come to management of endometrial hyperplasia with atypia or the EIN, which has an endometrial carcinoma simultaneously in up to 60% of people. What is the initial management? Women with atypical hyperplasia should undergo a total hysterectomy because of the risk of underlying malignancy or progression to cancer. A laparoscopic approach is better. There is no benefit from intraoperative frozen section. Postmenopausal women with atypical hyperplasia should be offered bilateral salpingo-oophorectomy together with total hysterectomy. On ultrasound, when a woman comes to you with postmenopausal bleeding and you do an ultrasound, a cutoff of 3 to 4 millimeters is observed for the endometrial thickness. Less than 6, no cancer has been found. This is the literature, except I had one patient who had a very, very thin endometrium, was continuously bleeding, and it did turn out endometrial carcinoma. So the cutoff is 3 to 4 if the woman is not bleeding and she has just come for a follow-up. But if a woman is bleeding and is postmenopausal, you need to take a cytology, a pupil biopsy, or a hysteroscopy, whatever is available to you as soon as possible. Postmenopausal women with atypical hyperplasia should be offered bilateral salpingo-oophorectomy together with the hysterectomy. For premenopausal women, the decision to remove the ovaries should be individualized. However, bilateral salpingectomy should be considered, as this may reduce the risk of future ovarian malignancy. And again, endometrial ablation is not recommended. Again, not recommended. Now, if she is a young woman and fertility preservation is desired, or the woman is not a fit case for surgery due to any reason. So women wishing to retain their fertility should be counseled about the risk of underlying malignancy and subsequent progression to endometrial cancer. Pre-treatment investigations should aim to rule out invasive endometrial cancer or coexisting ovarian cancer. Histology, imaging, and tumor marker results should be reviewed in a multidisciplinary meeting, and a plan for management and ongoing endometrial surveillance should be formulated. So it's not one person taking all the decisions. It has to be more people involved in the care of the woman. First-line treatment with LNG-IUI should be recommended, with oral progestrogens as a second best alternative. And once fertility is no longer required, hysterectomy should be offered in view of the high risk of disease relapse. How are you going to follow up this girl, this lady? Routine endometrial surveillance should include endometrial biopsy. Review schedule should be individualized and be responsive to changes in a woman's clinical condition. Review interval should be every 3 months until 2 consecutive negative biopsies are obtained. In asymptomatic women with a uterus and evidence of histological disease regression, based upon a minimum of 2 consecutive negative endometrial biopsies, long-term follow-up with endometrial biopsy every 6 to 12 months is recommended until a hysterectomy is performed. So the end point is you just have to do a hysterectomy for such a woman. Now, what are you going to do if she is desirous of fertility? Disease regression should be achieved on at least 1 endometrial sample before women attempt to conceive. Women with endometrial hyperplasia who wish to conceive should be referred to a fertility specialist to discuss the options for attempting conception, further assessment and appropriate treatment, because natural conception takes time and the patient may progress. Assisted reproduction may be considered as the live birth rate is higher and it may prevent relapse. compared with a woman who attempts natural conception and prior to assisted reproduction. Regression of endometrial hyperplasia should be achieved as this is associated with higher implantation and clinical pregnancy rates. So you have to have one negative report before pregnancy is you start your cycles and plan for pregnancy. Now, what about HRT and endometrial hyperplasia? Systemic estrogen-only HRT should not be used in women with a uterus. This is a grade A recommendation. All women taking HRT should be encouraged to report any unscheduled vaginal bleeding promptly. Women with endometrial hyperplasia taking a sequential HRT preparation who wish to continue HRT should be advised to change to a continuous progesterone intake using the LNG-IUS or a continuous combined HRT preparation. Subsequent management should be described as we have described before. Women with endometrial hyperplasia taking a continuous combined preparation who wish to continue HRT should have their need to continue HRT reviewed. Discuss the limitations of the available evidence regarding the optimal progesterone regimen in this context. Consider using the LNG-IUS as a source of progesterone replacement. And the rest of the management as we said before. Now, what about endometrial hyperplasia in women on adjuvant treatment for breast cancer? Like she is on tamoxifen. What are you going to do? What is the risk of developing endometrial hyperplasia on adjuvant treatment for breast cancer? Women taking tamoxifen should be informed about the increased risk of developing endometrial hyperplasia and cancer. They should be encouraged to report any abnormal vaginal bleeding or discharge promptly. Women taking aromatase inhibitors such as anastrozole, exemestane, and letrozole should be informed that these medications are not known to increase the risk of endometrial hyperplasia and cancer. So we have only tamoxifen for which we have to be worried. Should women on tamoxifen be treated with prophylactic progesterone therapy? There is evidence that you can put in an LNG-IUS which prevents the polyp formation and that it reduces the incidence of endometrial hyperplasia in women on tamoxifen. But the long-term effect of LNG-IUS on a hormone-sensitive breast cancer recurrence is uncertain, so routine use is not recommended. We do not recommend an LNG-IUS in a woman on tamoxifen routinely. How should a woman who develops endometrial hyperplasia while on tamoxifen treatment for breast cancer be managed? The need for tamoxifen should be reassessed and management has to be according to the histological classification of endometrial hyperplasia and in conjunction with the woman's oncologist. Basically, the management doesn't differ. The endpoint is a hysterectomy, but before that we have observation. Then we have 3 monthly, 6 monthly, if there is presence of atypia or not atypia, histopathology of the endometrium, and progestrogens that have to be given. How should endometrial hyperplasia confined to an endometrial polyp be managed? So complete removal of the uterine polyp is recommended and an endometrial biopsy should be obtained to sample the background endometrium. So you've taken out the polyp, but you also need to sample the background endometrium, which many times does have EIN. Subsequent management should be according to the histological classification of endometrial hyperplasia. So in conclusion, what I would like to say, endometrial hyperplasia is a histological diagnosis. No imaging, nothing is going to give you a diagnosis. It is a histological diagnosis. Total hysterectomy with bilateral salpingo-oophorectomy is the definitive treatment. In case of conservative treatment, histological follow-up is essential at 3 to 12-month intervals, depending on initial histological diagnosis, till definitive treatment is done. These are my references. And from the RCOG guidelines, the guideline number 390, classification and management of endometrial hyperplasia and histopathology, endometrial hyperplasia and coexisting cancers. Thank you. Thanks a lot. Thank you for a very patient hearing on what is a very boring topic to many people.
Dr. Asha Jain, madam, indeed, we are thankful to you. Actually, I must admit, am I audible?
Yes, ma'am, please go ahead.
Yes, yes.
Actually, I must
You're
admit
audible.
that this talk of Dr. Asha madam is worth recording, and it is often go through kind of talk. It's her clear takes on everything, may it be classification, diagnostic, surveillance methods, everything was so clearly presented by madam that many doubts have been cleared. Her clear take on endometrial ablation, cutoff in case of postmenopausal bleeding, management options for both fertility preservation and not. Everything was so clearly presented, madam. I appreciate your efforts. Right from data material, excellent slides and great presentation. Thank you, madam. We are indeed thankful.
Thank you. Thank you. Namaskar.
Thanks.
Thank you very much, Dr. Asha Jain, ma'am, and Dr. Pranjal Sharma. So, a wonderful talk on endometrial hyperplasia, as well as for conducting the session previously. We have an audience of about 500 odd people who's logged in, despite it being a postprandial afternoon on a weekday. So thank you very much to all the audience members for logging in. There are a lot of appreciative comments and a lot of positive feedback from all the audience members. So that's wonderful to note. For those of you who are logged in case you wish to have the ICOG credit point certificate, that button is now enabled. If you refresh the page, just click on the button and you'll be able to download the ICOG credit point certificate. There are one or two questions which are there in the audience chat box. And if you permit, we'll take these quickly. The first question is for Dr. Manisha Patrikar-Kakade. And the question is that you've covered all the antioxidants in wonderful, elaborate detail. But what is your take, ma'am, on the different commercially available preparations? Is there anything specific that we should look for amongst the combination that you normally see, which are being prescribed, which every single day probably some pharmaceutical representative is coming to you and saying, mine is the best, mine is the best? How would you approach that?
There is a very big race of them coming up, but I think any of them used wisely, selected wisely and used wisely will be more than enough. I cannot pinpoint just one company or one brand for this.
So there's no specific brand name or combination that you would normally endorse, but as you had said in your talk, that there are certain molecules that we should be looking for, specifically L-carnitine, coenzyme Q10. Some of the newer formulations incorporate these in the good therapeutic dosages. We have Dr. Ashish Kaya sir with us. Sir, what is your take on this controversy over antioxidants? I know your talk was on insulin sensitizers, but since you're a very excellent academician and a fantastic practitioner.
Sir, I have just joined. Can you repeat?
Yeah, so the question is specifically which antioxidant combination you would recommend, and do you feel that any particular formulation or combination is to be preferred over others? Because every pharma representative who comes says my preparation is the best.
Yeah. Sir, basically, when you are talking about the antioxidants, one must understood there are the two things like SOD and there are free radicals. If SOD is high, where your DNA fragmentation is high, where your DFI is very high. So in those cases, a potent antioxidant is a vitamin E and selenium can be added on. If you are just you are giving as an empirical, then zinc and other antioxidants are well enough. But when you're talking about the potency and SOD and a free oxidative species, then it is better to give a vitamin E as well as selenium.
Okay, thank you, sir. And the next question, incidentally, is for you. And this is regarding the use of insulin sensitizers. there are many companies which are now marketing combinations of metformin and myoinositol. What is your take on it? Do you feel that this is something which is superior, or it still requires a lot of study before we can recommend these kind of combinations?
Sir, as rightly been shown in a presentation also, when you wanted to give a metformin with a myoinositol and D-chiro-myoinositol, the first thing is like metformin causes a reduction in the weight. And secondly, a myoinositol and D-chiro-myoinositol will be improvement in the quality of the oocyte as well as the embryo formation. So when you are doing the patient with this particular combination in obese PCO where infertility is the issue, so definitely this combination is a long way to go.
So we still have a long way to go before we can widely recommend it. Maybe we still need more studies specifically in our Indian population whether this combination is effective. Until then, we have myo and D-chiro-myoinositol, which have been working well in Indian population in clinical practice. The last question is for Dr. Asha Jain, ma'am, and this is, I think this was posed by Dr. Varshalade. Are there any specific tissue markers or biochemical markers for endometrial hyperplasia? Just like we have CA125
No,
for
sir.
endometriosis.
No, IHC is under research, but so far we haven't got any markers. Their genetic studies for Lynch syndrome are there. So there are specific chromosomes which can be tested. If there is a family history, familial cancer syndrome, if you have, so you can check for that. But otherwise for hyperplasia, there are no markers.
I think that was covered very well in her talk where she said that familial polyposis coli syndrome is one of the predisposing factors, but then it's not so common in India. In endometrial hyperplasia, the only way to identify it early is to have good vigilance, good surveillance, and every time the patient comes to you, don't just put her on progesterone blindly. Make sure that a follow-up scan is done and endometrial biopsy is done. Dr. Varshalade has raised her hand. Yes, ma'am.
Yeah. In concern with patients with hyperplasia you are treating, you are sure that they are in a risk of moderate and a mild, and where you are just following them 6 monthly or yearly, and there we see that some few patients are progesterone resistant. There the role of tissue markers comes.
Correct. Maybe that is where we need to be proactive, do an endometrial biopsy, send it for histopathology, get a tissue.
So actually, we need to do a histopathology anyway. Correct. At 6 months, you're going to do a histopathology. If she's
in an ideal world, yes.
That was an excellent reinforcement, madam. Every 6 months, histopath. Like we also have to reinforce
symptomatic. Then you're going to do 6 months nothing, and you're going to do a histopathology. If she's symptomatic, you're giving her progesterone. If at the end of 6 months, in spite of progesterone, she's having symptoms, means she is progressing in disease, because she might not, because 60% of atypia will have coexistent endometrial malignancy in it, though it is not evident. So you have to consider it as malignancy and do a hysterectomy, and that is why you also remove the ovaries. Here you don't think of the ovaries. You are going to remove it because endometrial and ovarian malignancies together are very common.
Thank you. Thank you for bringing that point out so beautifully. We are at the end of the Q&A session. I would welcome any remarks from any of the faculty who are present before I present the formal vote of thanks. If anybody has anything to say which we have not covered so far, please feel free to speak.
Just a small question to Dr. Ashish. Ashish, you are here?
Yes, madam. Yeah.
Do you, like with routinely you prescribe something with metformin like methylcobalamin or etc. Because a physician, they do. So
Madam,
with the co-prescription?
With the metformin, I'll not give us some co-prescription, but definitely metformin I will be only adding when I'm doing my HOMA index.
Okay.
Yeah. And we are routinely doing it.
Thank you.
Yes, Dr. Varshalade.
Yeah, thank you so much. It was a wonderful session. First of all, for Manisha's talk, I would like to say we started believing in this unpredictable world. We started believing on vitamin C, zinc, everything for not even infertility. For everyone, we are prescribing now. Secondly, Dr. Ashish was really a best talk. insulin sensitizers. We are preventing the metabolic syndrome. We are giving metformin to the postmenopausal age 2. Physicians are prescribing. And Dr. Asha, wonderful. There are what I talked about cell tissue markers. They are in the research. They are it is yet to come, and hope for the best we can evaluate the hyperplasia patient. Thank you, President Dr. Nandita Palshetkar. Thank you, Dr. Secretary Dr. Arun Nayak, and our beloved Vice Presidents. And thank you, Pratik, for giving me opportunity for this session. Thank you.
Thank you, ma'am, for being here. So I'll just present the formal vote of thanks. Many of the eminent personalities have already been covered by Dr. Varsha. But as chairperson for the AMOX Endocrinology Committee, I'd like to place on record my gratitude to the AMOX office bearers, our esteemed President, Dr. Nandita Palshetkar, Secretary, Dr. Arun Nayak, ICOG Chairperson, Dr. Uday Thanawala, Secretary of ICOG, Dr. Ashok Kumar. Thank you for the ICOG credit points. 3 eminent stalwarts as our chairpersons for today, Dr. Kiran Kurtakoti, Vice President AMOX, Dr. Varshala Ade, Zonal Coordinator, and Dr. Pranjal Sharma, Zonal Coordinator. Thank you so much for sparing time from your busy schedule to be here. And we had 3 wonderful talks by 3 stalwarts again of AMOX as well as one national faculty. Dr. Manisha Patrikar Kakade for her talk on role of antioxidants. Thank you so much. I think all of us who have crossed 40 now, we need to start taking these ourselves. Forget about prescribing these to our patients. Next, Dr. Ashish Kaya for a wonderful evidence-based talk on the new insulin sensitizers which are now available to us. And last but not least, Dr. Asha Jain, ma'am, President of Raipur Society, who is contesting for the Toxicity Committee post. Wish you all the very best in your attempt, and we are sure you will win by a handsome margin. Thank you for the lovely talk, which was updated and made, I would say, late last night, going above and beyond the call of duty, speaking on endometrial hyperplasia. Thank you to our academic partners, Acumentis Viviana, for partnering with us. And also gratitude to Science Integra, Subbu Session, and Shriman for being our broadcast partners for today's event. We have nearly 500 people logged in to today's program. We look forward to seeing you in the next event, which will be after the Ganesh Festival. We'll take a short break for about a week or 10 days, and then we will be back with you. Until the next time, goodbye, God bless, and stay safe. Stay far away from Delta variant of Corona, and wish you all the very best.